my story that are really typical, and then there are aspects of my story that are atypical. And I'm gonna
come out and represent such a positive, healthy role model of recovery.
We have what we call the Alliance in Billings, which is the 3 major healthcare providers.
The day when he's really alert and can focus on his work. And then somebody this morning talked
into getting the world a better place. And it's both true, because the professionals actually need the resources, the payments.
Some of the policies that we are driving are targeting those kinds of issues, but it's not like it's
analogy as opposed to an electrical line analogy, the circuitry and learning.
This presentation is basically a description of how one community created a crisis response system unique to that community, and that would be the Billings Clinic and our affiliate healthcare providers in Yellowstone County. And then the Missoula Coalition and their efforts and what they're trying to do to create a similar process in the Missoula area. Did I say that correctly? Okay. Just to give you some background, about almost 4 years ago, we have what we call the Alliance in Billings, which is the 3 major healthcare providers, which is the City County Health Department, the Billings Clinic, and the St. Vincent's Healthcare. And what we do is select the CEOs and select members of the staff for those agencies get together quarterly and examine the broader healthcare needs of the Yellowstone County area and region, and we define what it is that we're going to assign a project to, and it's usually focusing on the uninsured, underinsured, and the disadvantaged populations that are not accessing appropriate levels of all healthcare. And so about 3 years ago, we were assigned the task of addressing the mental health and substance abuse issues in our communities. One of the driving forces in that was the 2 emergency departments for the hospitals were getting flooded with people needing mental health care, and they were using the EDs as their first point of access into the mental health system. A lot of these patients were not in need of emergency services or inpatient services, but they were just in need of referral. They needed prescriptions, they needed access. And so what we try to do is design an access point that was no wrong door. One of the other larger goals that I think is very important to point out is that we do have a psychiatric facility in Billings at the Billings Clinic, which is about a 44-bed facility. But what was happening is those beds are getting filled with patients that were needing less than 24-hour care, meaning they were intoxicated, they were having a mental health crisis, and we were admitting them, and then they were checking out the next day. What happens with those situations is then those beds are not available for those who are really acutely needing serious mental health care. And so we were trying to be good resources, stewards of those beds so that they were available for our surrounding communities and counties so that that there was access. The other thing that was a driving force in this initiative is that we did shut down beds at the Billings Clinic, which is a common occurrence going around the state and around the nation, is because it's such an expensive service to provide and it's not reimbursed well. And so it's a large part of our charity care, which is fine, and we believe in that, and that is part of our mission. But we had to get some sort of a better handle on that expense. Inadvertently, what that caused was pressure on St. Vincent's Healthcare to admit patients to their emergency or into their ICU and to their medical floors, and they were not prepared to handle mental health patients, and then they couldn't transfer them to us because we were on divert all the time and we didn't have beds available. So it really brought the important players to the table to say, what is our bigger solution to this problem? So a little bit for perspective, just from the Billings Clinic, about 45% of all of the people that are presenting in our emergency departments have a co-occurring issue, meaning they have a primary mental health problem or a primary substance abuse problem, or they have both. If you look at the number of visits we get, it's a very disproportionate amount of our visits. Most of these people have no insurance and have no way to pay for this service. PAC, the PAC, that's our psychiatric assessment clinicians that we house in the Billings Clinic emergency departments. Those are licensed people that do the evaluations for us and then consult with the psychiatrists to determine the disposition, whether we admit them or they can sign a safety contract and be discharged on their own accord. So essentially the model we chose was the 4 sponsoring agencies became a limited liability organization. So we have all of the not-for-profit 501(c) status that all other nonprofits would have, and all of the legalities that go around forming that. Our governing body is a board of managers. We picked 2 from each hospital because the 2 hospitals are the major financiers of this project, and then 1 from each of the other voting sponsoring agencies. I am the vice chair of this board. The City County Health Department provides the chair. We also have a physician from each emergency department that represents each hospital on this board. We're developing an advisory council. This has been a little more difficult to get going, so these are part of our next steps. But we do have community providers, community resources, and then city, county law enforcement, and then consumer and community members that will be part of our advisory council. We also have a medical director who oversees all our policies and procedures. Any questions so far?
Is the medical director a psychiatrist?
No. Our goal was to be open 24/7, 365 days a week, a year. And then in the beginning, when we were trying to hire the staff, we couldn't be open the full amount so only halfway through the year did we end up being open 24/7. It's a licensed outpatient facility with the state of Montana. We did have to rewrite administrative rules to create a crisis center licensure process. So that was quite an involved process. We do have a full-time director who is on site and reports to the board. And she's also a licensed clinician. All of the agencies provide the staff. The Crisis Center does not employ their own staff. So the Billings Clinic provides all of the mental health professionals and the mental health techs. The St. Vincent's Hospital provides for the RNs and the administrative support people. The Mental Health Center rotates their case managers through to provide case management for those that are coming in. And so that's sort of a unique setup and can be quite challenging. Our entire intent was to triage and assess the needs of all these people and then refer them to the appropriate agencies. It was not initially to provide treatment per se in the traditional sense. It was not to duplicate services that were already available in the community, but create a no wrong doors so that we could redirect them, create a crisis plan, and start tracking whether they were attending appointments, why they couldn't get to appointments, whether we needed to drive them to appointments. And so we've created niches in the Mental Health Center and some of the other organizations where they open slots for our referrals so we can get people in more immediately. So this has been a huge community-wide effort. And we also provide 24-hour security, so we have a person there all the time that's a security person. Initially, we had asked and wanted the city police department and the sheriff's department to help us with that, but they weren't able to do that. So essentially our mission statement, and this is an evolving process, but the Community Crisis Center will provide assessment referral services to people in crisis who need access to integrated mental health, chemical dependency, and social services. The Community Crisis Center will be a leader in the development and implementation of an evidence-based integrated crisis model. And our goal was to create a single point of access and a community system of outpatient care for people with mental illness and co-occurring mental illness, substance abuse disorders based on no wrong door philosophy while reducing excessive use of costly but less effective resources. The no wrong door, we did add to that to meet, say, and this is the Minkoff model. I'm not sure how many of you are familiar with the Minkoff model, but when you walk in the door of the crisis center, above the door it says no wrong door every time, because some of the training as us as mental health providers has been an issue of when people are non-compliant or are not taking their medications, that we've tended in the past to fire people and ask them not to come back unless they're compliant. And that's a historical philosophy that we are really challenging at the Crisis Center. So no matter how many times you're in crisis, you're welcome. And it's a welcoming environment regardless of what your issue is, whether you were there the day before or that morning, that we will welcome you and we will assist you. So it's a very different model, and some people are struggling with that. So we're challenging our thinking, and the Minkoff model has been very helpful in helping us challenge that and always creating an atmosphere of hope and a belief that people recover, and that's always the philosophy with which we approach people. These are just some statistics. There's approximately 25,000 adults in Montana with co-occurring diagnosis. These folks are difficult to manage, and over 50% of them have no insurance. I'm going to say that more than that have no insurance. At the Crisis Center, 80% of the people that are coming in our door do not have any insurance. In 2006, the Healthcare Alliance did a community-wide survey and identified mental health and substance abuse as one of the 9 top priorities in what is needed to be addressed in our community as far as healthcare. By default, the ED becomes the point of entry. And so, it's being used for crisis response, primary care, social services, bed, food, shower. And so this is really to duplicate that in a different setting, and it's being very effective that way. So this particular population we're trying to target is associated with increases in relapse, hospitalizations, violence, incarceration, homelessness, and serious infections. I'd also like to add that people with serious mental illness and substance abuse also become very physically ill and compromised. And so what we end up seeing is people in serious medical crisis on top of their mental health crisis because the mental health piece has not been treated. And in the larger picture, we need to really start addressing that from a broader healthcare perspective. And so some of the trends going around the country now is what we'd call a same-day care or urgent care for mental health. Those are the models that are becoming much more popular because sometimes people can't keep their appointments or forget about their appointments. So being able to access care when you need it. If you have an earache, you can go to same-day care and get that treated. It should be the same if you're having a symptom that you need to get managed and need that kind of care. So we need integrated care to keep them from decompensating and from developing other serious health problems. So this is not only a local problem. We all know that this is a statewide, national problem. And we try to develop our Crisis Center program around the initiatives that Addictive and Mental Disorders Division has been putting into place over the last several years. So we're trying to keep things at the local level, promote safety and decrease the suicide levels. Montana's got the second highest suicide rate in the country. One of the things that is contributing to that is that we have a lot of access to weapons, a lot of guns in Montana. So we do see a lot of gunshot wounds. We're also trying to prevent placements at higher levels of care that are unnecessary, provide integrated care, to maximize our third-party payments, decrease the time that law enforcement is having to spend with people with mental illness. We've developed a very strong CIT program in Billings that was initially very, very challenging, but we've now got a new police chief who is very much in support of that. So what we're experiencing now is the sheriff's department, the police department, instead of arresting people, are picking them up and bringing them to the crisis center. So we're seeing a significant decrease in the population in our in our county detention center, which was a side effect we had hoped for, but it wasn't necessarily something we set out to measure. So that's very, very exciting. We wanted to develop a closer relationship between physical and mental health, looking at the holistic approach, and have a secure placement for people with that needed mental and physical assessments, the diversion from jail, and then also our linkages to all of the other agencies in the community. Yes?
So do you have a safe house that's associated with this for those people that maybe need an overnight stay?
We can keep people up to 24 hours. So we have what we call observation areas. So they're monitored up to 24 hours. Our average length of stay, I think it might be on one of these, is about 10 to 11 hours if they're needing observation. A lot of the people that we're seeing are just needing assessment and a referral to another provider. So again, just a single point of access. So when people are in crisis, they know to go to the crisis center. They don't have to think about, do I go to the mental health center? Do I go to the emergency department? Where do I go? Again, the no wrong door philosophy, reduction in the excessive use of costly and not effective resources. The EDs are not equipped to provide mental health care. The ED staffs are not necessarily trained, and so we want people going where people have expertise in treating mental health issues. So we also have an integrated psychosocial assessment. We're in the process of evolving that because it's actually a very lengthy assessment. So we're trying to modify for those that are continually returning to do a little more modified assessment. We do a nursing assessment, so people are getting their temperature taken, their blood pressure. What we don't want to have is a medical crisis. So if people are needing medical detox, they are being referred back up to the EDs, and we alternate them between St. Vincent's and Billings Clinic. We do not want to become a medical facility. But most of the time, we're being able to manage that, so. Okay. So we're looking to have a seamless service. Pathways is a program where we're entering all this data into a database. We ask the patients to sign a release. That information is then shared between all 4 healthcare organizations. So when they're showing up at all of our different places, we can look in and see what the need was, what they're referred to, what their crisis plan is. And so we're working together on how to treat that patient. And so they're not going to fall through the cracks. So we're the first one to be licensed as a crisis response with 23 hours, which was very exciting. We are now building up telemedicine with other emergency departments. We're starting with Big Timber, looking at Livingston. We have 5 others that we are have agreements with, where if they have a person in a mental health crisis in their ED, they can hook up with the crisis center, and we can do an assessment through telemedicine with one of our licensed people, so we can hopefully avoid unnecessary transports by the sheriff's departments, perhaps get the patient to sign a safety contract and kind of just get a better handle on what their needs are. Right now, what the EDs do is immediately put them in the sheriff's car and take them to Billings Clinic or to the state hospital. So we're really trying to network with our partners in our surrounding counties and our county hospitals. So we're trying to provide a reproducible model that potentially has a statewide solution. So this is kind of some statistics. When we first opened, these are the calls that we're getting. So we also do crisis call. Interestingly enough, when we did go 24/7, our calls went down a little, and we're not sure why that happened. Probably because they were just coming in instead of calling. This slide shows after we opened 24/7 that the average numbers, as you can see, went up dramatically. I think at this point, after being open a year in July, or in June, we've had probably 3,500 visits to the crisis center. The two hospitals we have to measure whether we're impacting our volumes in our hospital system. So the two hospitals picked these diagnostic codes, or ICD-9 codes, and we'll track these to see if we're seeing any reduction at the hospitals in these particular codes. And so when we're going to our affiliate hospitals, we're also asking them to track this too, so we have some consistent data going across the state. This is the utilization. Like I said, back in June there was 2,200, but it's way up there now. Of those, about 800 of them were not duplicated. The average length of stay is about 11 hours. But of all of those, only about 578 of them needed observation. That's the calls we're seeing. 76% of the clients are meeting the criteria for severe mental illness and also having alcohol and drug-related issues. So there's a huge number of people that are not accessing the mental health system who are very severely ill. And so I think that's very telling of sort of the limitations of our system. About 80% of them have no payment source. 46% of them are Native American, 46% Caucasian. 65% of them are homeless. Most of them are male. Their average age is about 40. The reason they're accessing us is for mental health services, for basic needs like food, clothing, and housing, and then medical care, and lastly, for addiction treatment. I think this speaks volumes to what an unmet need is out there that's probably in all of your communities. I know this is not unique to Billings. So I just feel this is really giving us some good data so we can start developing services that are targeting these populations. With our emergency department, with the codes I just showed you, about 11,000, a little over 11,000 of the visits we're getting, of the 23,000 are mental health and alcohol drug related. The interesting thing that we were hoping to do is when we're referring them from the EDs to the crisis center, the people that are continually refrequenting the EDs are now returning back to the crisis center and are much more happier with the service. And so they're refrequenting. We want them to go back to the crisis center and not back to the EDs. And they're developing relationships with the counselors. Our satisfaction surveys are excellent, and they're very, very happy with the services they're getting. So how did we get this going? Initially, the hospitals agreed to fork out the money for it. But what was really an amazing process is we found a building that had to basically be gutted. We had an architect volunteer his time, and he took hours and hours and hours as we tried to design the environment for this. And that was all volunteer time. Then we had all these contractors that at the time were putting up our big trauma center in Billings and then working on other projects in the city. And they all volunteered their time and materials to build the inside of it. We had to pay for the doors because the doors were specialized. But essentially all of the inside, all of the equipment, all of the furniture was all donated. That probably was about $500,000 worth of labor and materials that was donated by the Billings community, just people in the community. We did get a grant from AMDD that helped us with some things. We got a justice grant. the self-pay bill, you know, we don't expect that we're going to get paid, and that never was an expectation. There's some people that do have insurance. That's probably not going to put much of a dent in this. There is the 72-hour presumptive eligibility that's out there that we're hoping will help a little bit with this. And then just looking at other grants and telemedicine and other opportunities to fund it. And that's what the Crisis Center looks like. The other thing that I think is really important to point out is that our next needs is we need physicians that will help us with prescribing here. We don't do any prescriptions here, but you know, those are some next steps that I think are challenging to all of us across the state. Is we have a terrible shortage of psychiatrists. Even though we have a lot of psychiatrists in Billings, they still can't meet the volumes that we're trying to see, especially the public volumes of people that do not have a payer source. So I think coming up, the challenges will be workforce development. The Billings Clinic and the City County Health Department have been having some good discussions about a 3rd and 4th year psychiatric residency program, if we could bring it into the state from Washington and start helping seed the state with psychiatrists. But that would take some startup funding. Were there other things that we talked about that you wanted to touch on?
Obstacles. How do you want to talk about that?
The obstacles?
Go ahead.
I think there are obstacles to creating a system like this. I think we're very lucky in Billings because the Billings Clinic and psychiatry has always been a big part of their mission. St. Vincent's, you know, believes in psychiatry, but it has never adopted it as part of its mission. So getting 4 organizations together initially to agree that this was our community problem was very challenging. So we had some pretty intense discussions around the table about who's responsible. And we finally agreed we all were. And I think those are the conversations you have to have in each one of your communities. Some of the other, just the funding, you know, how do you fund this? This is essentially a $1.4 million a year project that the hospitals right now are sharing the costs for. You know, we probably, as hospitals, are not going to sustain that forever. But, you know, we felt it was important enough. The other thing that's an advantage is there's some new regulations regarding nonprofit status. And so how you measure that is going to become more and more important. One of the things the Community Crisis Center, it meets every criteria of the national standards for doing charity care and community benefit. It meets every one of the criteria. So in that way, it serves hospitals, nonprofit hospitals, to be engaged because it really does demonstrate their value as a nonprofit to the federal government. So there's some hope there, I think. I also think that the challenges for the smaller communities is, again, having the staff, having the access to telemedicine, having access to providers. We don't have enough mental health workers. We do not have enough licensed people. We do not have enough doctors. So, and that's a national issue. It's not just Montana. So we're going to have to really work hard at that.
Questions?
Any questions?
We have finding hard problems with things that you're not going to have too many people that are going to be paid off very well because you're all going to need to pay a psychiatrist or folks you can hire.
You know, you can. I think you're asking about the availability of psychiatrists and paying for them. Psychiatrists are very expensive, but worse than that, even if we had the money to pay for them, they don't exist. Our country is not producing them. We have not incentivized psychiatrists to go in. Yeah.
You can't, and they won't go anywhere.
Well, and we have psychiatrists, but they don't, we have probably, if you look at the number of psychiatrists, there's quite a few, but not, most of them will not do public mental health. They're not going to do the call to the EDs, and they're not going to do...
That was the question was why was that so?
Why are we not producing psychiatrists?
Some kind of, how do they are permitted to work if you can't find someone who's capable of doing that? And how are they trained to do all that besides just college and MSDs and all that, doctors and things like that?
Well, we're looking at primary care and mid-levels, and how do we train them and use psychiatrists on a consultant basis. Yes?
That seemed like a huge percentage of Native Americans. Is that right? Is that a huge percentage of Native Americans?
Yes.
What was your percentage of Native Americans?
Almost 50%. But the other 50% are Caucasian, so I mean, I guess it depends on how you look at that.
Have you entertained the idea of using the nurse practitioners in place of the psychiatrists?
We use a lot of mid-levels, and but they're kind of hard to come by too. And the PAs actually have to have supervision by medical. Yeah. The nurse practitioners can practice more independently, but also have to be certified in psychiatry. So, but yes, we're trying very hard to recruit those as well. Yes, Jean?
Have the numbers of people coming to the crisis center helped you have a better understanding of the difference between the services that are available in the Billings community and the services that are needed? In other words, what additional capacity you need on the community level? You know, has it enabled you to quantify that? I mean, obviously there's a gap there, but.
There's a lot of these people that are on a waiting list to get into the mental health center.
So are you using the numbers that you're seeing in any way yet to make the case for some more specific level of increase in capacity?
Yes, we will be.
How are you doing that?
That'll be next presentation next year.
Good answer.
No, I mean, we didn't really know what to expect. I mean, we did this with the hypothesis that we were going to capture a population. We really didn't know what that population was looking like. And our theory is that we're providing a lot of services, but are we really providing them correctly and to the correct population, and what is the access problem? And so the Pathways program and our numbers, and especially what we're measuring from the hospitals, will determine a lot about how we evolve this service and how we connect with our fellow providers. Does that make sense? Okay. Any other questions?
Have you been tracking at all the cases that you see that if the service wasn't provided by your organization, that they'd be sent off to Warm Springs? Have you been trying to track that at all to see how much of a cost savings it is to treat within the community versus sending to Warm Springs?
Well, I can go two different ways with that. Initially, the crisis center was not intended to impact the state hospital. Frankly, our inpatient unit at the Billings Clinic, if you look at the numbers going to the state hospital, they're not coming from Billings. I mean, we're already taking care of our group pretty well. So I don't expect to see a significant number being affected that way. On the other hand, if you just look at evidence-based practice, if people access care and have immediate access to care, they're less likely to decompensate, less likely to end up in our inpatient unit, and less likely to be committed. Does that make sense? Yes. Okay. Anything else? Jean?
How is your crisis telephone service coordinated with the crisis phone service at the mental health center provides?
We don't coordinate it that. We just, if they call, we record it and make a note.
So they're two separate?
Yes.
Have a phone system of the on-call and 911 and stuff?
We do as a community. Ours is just you call the crisis center and we're going to talk to you. It's not identified as a public system per se that's identified that way.
How many psychiatrists do you need, and how many do you have?
How many psychiatrists do we have? None that go to the crisis center.
Well, I'm in a community center like that, you wouldn't have one there. Where did they get a hold of one? In Billings?
Through our emergency department, we have 14 psychiatrists that share the rotation to the public system that reports to our ED. Those belong to the behavioral health clinic at the Billings Clinic, and then the others belong to the mental health center. We have one weekend hospitalist who is there 24/7 over the weekend, who handles all of that. And then we have a hospitalist that's in our inpatient unit all day long who does the intakes for the most part. And we also have a child person who's on site at the psychiatric hospital half-time who does those. We have 4 child psychiatrists.
They're not actually a crisis worker. They're more or less giving them a chance to have a psychiatrist, and then if they have a crisis, they'll call someone to handle their problems.
Historically, what has happened is they call the mental health center, or and depending on the situation, they'll be referred to the Billings Clinic's emergency department, where they will be medically stabilized and evaluated, and then the psychiatric assessment clinicians will evaluate for their acuity. Then they call the psychiatrist to determine a disposition.
I'd like to know about peer-to-peer counseling. Is that something that...
That's in our goals to come forward to bring into the crisis center. Yep. We haven't gotten that far yet.
I'm
Sure. Yes, we very much value that. And we do have RAP training. We do all the CIT training is developed out of the crisis center.
And DBT?
And DBT. We just had our director trained for a week in DBT, and so we will be starting to train the rest of the staff in that. It is co-occurring. We're working very hard on the Minkoff model and training people on Minkoff.
If you don't have anyone there with prescriptive authority, so how do you stabilize these folks without any medications or gotta miss something?
A lot come in with their own meds, and so we keep them from them, and then we give them to them to take as prescribed on the bottle. If they need prescriptions, we use the City County Health Department or the Mental Health Center or the Behavioral Health Clinic, and we refer them and try and get them in as fast as we can.
How do you advertise? And how do people find out about you?
We have done many public forums. The Billings Gazette is very great at giving us press. We've gone to the City Council. We're trying to get on the City Council's agenda again. But all of the agencies, our other social service agencies, have all been very instrumental and partners in us developing this. So they're very grateful for a place to send people. Yeah. Yes?
Do you see a role for telemedicine for psychiatrists consulting into the crisis center?
That would be a goal.
And if you had someone with prescriptive authority there, given the demographics of this population, would you be able to provide medications or resources required for medication?
We have fairly rich resources in terms of MAP and donations for medications. Our NAMI program actually sponsors a medication program.
Just one last question. I thought I had seen you had on there that this program is reproducible in other. Is that?
Well, we would hope it would be. I don't know that this exact model is going to work. One of the things that I think people have to be very careful about is, we didn't add a service that was already in Billings. It was a level of care that was not being provided. We didn't want an inpatient facility. We don't need a BIF because we already have an inpatient unit. But it could be the groundwork for many communities to design something that's unique to their communities and the resources they have in their communities. I'm not saying every community needs a crisis center. But the thinking.
Small communities.
Sure.
there could be some things.
I think was our biggest hope is that people would see that if organizations, the healthcare providers, and a community can come together and create a solution. This was just our solution. So, but that was the hope we hoped to give everyone else. Yes?
Do you hire security? Like you're a security company or?
And they're there 24/7.
Joan, could you share some secret tips about how you got these different agencies to work together? Because I realize it involves a lot of money, and that is often the big stumbling block.
Well, I think because we have the Alliance, which is a dedicated group that's committed to addressing the unmet healthcare needs of our community at large. When you sit around a table and you have agreed that you work together as a community, I think it's really hard politically for one of them to say no. So, I mean, because it doesn't present well publicly. It doesn't look good in the newspaper. You know, that one partner said, well, we identified this huge community need, but one of us decided it wasn't our problem. I mean, there's political pressure involved in this. So you have to kind of leverage that and leverage your legislators and your funding sources and really have to get at people's hearts and let people know that this is important and it's valuable, and the role of the consumer in advocating, NAMI and the other organizations that have really supported us in making this an important issue for Billings.
So the Crisis Center, you have different organizations for which you have legislatures, Montana money. Will it come from?
We have not received any money, no, except from AMDD. Thank you. There was no money legislated for crisis services as we provide them. That money was used for different things like CIT training, RAP training, a few other different needs that we had that were not related to direct care. We didn't expect it, but I think it's important. I guess I'm hoping in a couple of years we'll see that we've really impacted the health of our general community and that we can bring that back to the legislature and say that this is a worthy model.
I'm sorry, there was one more question.
How does this relate to Lake County? I mean, your presentation and your...
Maybe I can take it from there and give us a few minutes and we'll try to tie that in for you. Would that be okay? I'm Daniel Moorhead with the Mental Health Crisis Prevention Coalition here in Missoula, and also with me is Helen Arndine and Jerry Stewart. Some of you may know us already, some of you may not want to know us, but we've been a consumer and consumer advocate voice here in the Missoula community. Before we get into that, a couple of things I'd like to do in the interest of time, though, is just real quickly, is I think Joan did a great job. She probably didn't really relay to you all of the personal struggles and difficulties that were gone through with that and the community.
A baby like that is bloody business.
This is bloody business. So we'd like to applaud you. Thank you, Joan.
I won't be having another one anytime soon.
Okay. Secondly, the coalition here in Missoula, and I'll tell you just very quickly what that is for those of you that don't know, did ask some guests here, as well as there's some people that are attending the conference that have been very supportive, and we'd like to acknowledge those. Starting off, Kelly McQuiston with Congressman Rehberg's office is here. The congressman has been supportive from the beginning of some of the things that we have advanced. State Senator Greg Lend from Senate District 50 is here as well, who has also been very much an advocate and a supporter. Mary Hutton, I think, is in the back of the room still. Mary, are you there with St. Patrick's Hospital? She's Community Affairs Officer. She's has attended our first meeting back in June as a ad hoc community group and has been very helpful and a great resource. Sue Englert is here. Sue, where did you, there you are, from Community Medical Center. I'd just like to acknowledge you. Thank you for coming. Both hospitals are represented here. We really think that's a step forward for the Missoula community. And Dan Ladd, State Planner for Mental Health with AMDD. He has been a great resource for us as consumers and consumer advocates to try to point us maybe in the right direction at times. I think those are a few of the, did I miss? Patrick? Well, right. Well, Patrick Wayne is the, those of you who are familiar with the Service Area Authorities, is the new chair of the WSAA. So Patrick has taken on a big job, and we thank you for that. We kind of got started late, so I'm going to make a really quick presentation, and what we'd like to do at the end of the session is maybe do some brainstorming around that. But very quickly, the coalition, what is the coalition? Many of you are probably wondering. Truly, it was an ad hoc community group here in Missoula that started discussions in late May, early June, centered around the fact that we have a psychiatrist that announced his retirement with a caseload of 600 patients with no referrals. And all other private practices in Missoula were closed. As consumers, consumer advocates, we first bemoaned the fact and then said, well, wait a minute. We have to get involved. We have to do something. We want to be part of the solution. And so that's what we really see the coalition doing. It's consumers, it's advocates, it's NAMI, who is very supportive of our efforts from the beginning, and the providers, the hospitals, the private psychiatrists, the counselors. We had representatives at our initial community meeting, well, actually not our community meeting, our first organizational meeting at the beginning of June, which led to a community meeting hosted by St. Patrick Hospital at the end of June, which was a springboard for some ideas. And what we see the coalition doing is really being a catalyst, trying to help consumers find their voice and help collaborate. Because what I've heard from various sources is that Joan talked about the way the Billings community solved it is really each community is going to have to look at this independently and figure out what's going to work in their community. We're not advocating that Missoula needs the exact same model or Kalispell or another rural community because everyone is unique. The infrastructure is different. And so we certainly are not advocating that we duplicate that model, but we thought this was a very important to hear as far as this is one community's response in Montana. I've got a little bit more, but just part of what our mission was to raise awareness. You'll see posted on the back of the wall some newspaper articles from the Missoulian. Tyler Christensen from the Missoulian, who was at that time health and business reporter, has been also very supportive. I didn't see Tyler here today, but she started off with just letting the community know about the shortage of psychiatrists, the retirement of the doctor, no referrals. Also has helped some publicity along the way with, there is a HPSA, which is the Health Provider Shortage Area application that Mary Hutton brought as an idea to the first meeting. And we have tried to help that along. Again, that's the collaborative part that we see. The consumer needs to be part of that voice, and hopefully we've helped in some fashion in doing that. And the last article is a weekly paper. It's called The Doctors Aren't In. And that was really with the intent of telling personal stories, taking stigma away from coming out of the closet, if you will. And I saw that somewhere in some of the research, is people need to come out, let the representatives know, find a voice, and not, I guess, hide, if you will, on that. I don't want to take a lot of time because we're running pretty short, and what I'd like to do is, with the last portion of the session, is do a little bit of brainstorming, ideas, what do we need to do, more of an interactive. But before I turn it over to Helen to do that, any questions about the coalition or what I've covered? Either it was really boring or I did a good job.
In the process of getting the community crisis center open, I just want to know the Health and Human Services Interim Committee was very, very supportive and a tremendous sounding board for the challenges that we had in trying to figure out this model and how it was going to work, because it was unique. And I just wanted to acknowledge that.
Thanks, Jim.
Do I need a mic? I have a very big voice. I'm going to engage Jerry. She's going to do the headship since I have difficulty with that department.
Can everyone hear, or is that going to be
Can you hear okay? Yeah. Fine. I'm Helen Orndine, and we get a chance to develop a wish list. Joan, you did a fabulous job in stimulating us and feeling like there's hope. There is a way to solve some of these problems. And we're going to talk broadly about Montana because I realize not everyone is from Missoula. So these crises occur statewide. Now, Joan mentioned the need for perhaps a psychiatric residency in Billings.
Missoula. I don't think it really matters at this point.
Somewhere in Montana.
What we know about residents is that if they usually will end up, a good portion of residents stay in the communities that they do their residency in. So that seems like...
That provides a nice incentive. In other words, if we were to get such a facility, I guess we'll call upon the senator to tell us how we get such a... I mean, does it require a lot of money? Or, and of course, 09 is coming up, and we've got to get our wish list going. So what are we talking about in terms of money? The seed money, is that what would be needed?
It's about $300,000 a year is what it would take to get it started.
And that's just for
the residency. That would be to hire a psychiatrist that would have to be the lead academic champion for it.
Does everybody understand what residency is and what we're talking about? Melanie, maybe just real quickly.
Yeah, Dr. Lind is also a medical doctor, so if you want to, we're putting you on the spot. You want to explain a little bit about residency?
After 4 years of medical school, their postgraduate training, and it varies, and I'm not current. Is it 4 years of psychiatry residency? It's 3 or 4 or 5?
Yeah, the first two in the University of Washington go, the first 2 years in their residency is in Washington. And then there's now a track in Spokane, there's one in Boise, where they do their 3rd and 4th year.
So the 3rd and 4th years in Montana somewhere, and there needs to be structure, oversight, and quality measures to provide breadth and depth of appropriate training and oversight of clinical care.
Yes, it's a big undertaking, to say the least. It's not to be taken lightly.
So how does the group feel about such an idea as a psychiatric residency facility in the state of Montana, not necessarily in Billings or Bozeman or maybe Missoula?
I think it would be very appropriate with Western Montana Mental Health Center in Lake County. As you know, that we're way down on psychiatrists, and I have a psychiatrist that gives children and adults prescribes for both, that comes up to 2 offices in Lake County 5 days a month. I need a psychiatrist a minimum half-time in order to fulfill the needs of the communities.
So perhaps there might be some merit in developing a bill for the question, comment?
Well, with respect to the residency, we've got 2 universities with nursing programs, and we are not going to have master's level APRN programs out of those universities. I don't know what the feasibility is of that.
Maybe dovetail something with the
If you're talking about
APRN.
hiring mid-levels, I think a bigger question is, why are there no psychiatrists? We have world-class cardiologists and neurosurgeons coming to Missoula. It must be there's no money in psychiatry, so where's that kind of land at a larger level? If there were money in psychiatry, perhaps more people would be interested in going into that field.
Can someone respond to that question, Mary?
Well, I just wanted to provide a little bit of an update. We've had a conversation with the MSU College of Nursing to do exactly that. They are interested in developing an APRN track within the MSU College of Nursing. Currently, we here in Missoula and other sites across the state of Montana do provide kind of clinical sites for a lot of Walla Walla or Gonzaga students. And so we're very excited that the MSU College of Nursing is very interested in developing that. And so that could very well possibly be something that they may need some startup funding to do. But as we all know, the academic world has to do, they have to go through a certain amount of internal review and assessment to make sure that that works for them, but they are very interested, so I think that that's certainly a move in the right direction for Montana.
Would that require some special funding?
I think so, but I'm not sure what that would require.
So we could say need for psychiatric residency, APRN, would be considered APRN?
Yeah, and that is currently being discussed now, right?
Yes.
I hope you'd build in or facilitate diversity, Native Americans, into that.
Now, how would you suggest that be done?
Well, how would you do that?
Yes.
Well,
What is your
to start identifying a need and kind of getting information out to different Indian communities, kind of facilitate that as a possibility for the future. To identify the need in, well, like 46% of the people are Indian. And to me, that must be the lack of access or some reason for that. But to educate tribes or Indian communities, that would be an option. And you guys, the people that are doing it, to facilitate sucking in or enticing Native Americans or African Americans or.
But increase awareness to the Native American community?
That would be one part of it.
Okay. Yes.
One of the things that we're doing in Lake County is we're trying to build an alliance right now, and I know I'm experiencing probably some of the things that you experienced in the early stages to try to bring all of those factions together. And one of those that we're working on is with the Salish Kootenai tribe and trying to build, bring them into the alliance and the alliance response in Lake County and how we're going to do that. But building that alliance is extremely difficult, not just with the tribal, but also with the two hospitals and with the counties.
I was just going to say, in some place, I think this is a statewide problem. We should look statewide. I know there are some, you look at the admissions to Warm Springs, for example. There's a regional, they break down into different regions. And I think as this moves forward, all of these plans, we should look at being strategic with where to first focus. I mean, each community is going to need care, but I think part of it should be a strategic plan as well for the whole state. Butte, I don't know if there's representation from Butte at the meeting, but
I'm from Butte.
In terms of taking credit for some of the potential benefits with respect to utilization of the state hospital and improved care, and also share as Billings has done with benefiting perhaps the law enforcement community and try and come to the resources. And we're going to have to look many different places to get this big project done. But
You have to spread it out, do you not, given that it's essentially a rural state and you want easy access among the rural communities?
Yeah, and I think the service area authorities have to be a big part of those discussions in the local advisory councils, and they have to be major stakeholders in this development as well.
Okay, yes.
I'm a little confused. You were talking about building a psychiatric facility. Is that what you're talking about?
No.
Well, do you want to address that, Joan?
Well, there is the BIF that was legislated last year, and I mean that's potential, but you don't need a facility to build workforce capacity. We have facilities, I think, that are adequate to, if we develop them appropriately for the clinical value they would need to offer. I don't think a facility is necessary.
I see. Well,
We need a facility, we would need a facility for the center. That would be one of the needs.
If that's what you chose to do.
This is, what you're suggesting is we have enough buildings, they would just be included, is that right? Or
I just am suggesting that not every community needs a crisis center. I'm just saying that if I'm focusing more on the workforce development.
Well, I think she addressed the psychiatric facility.
Well, you said, what I wrote down was that you were talking about building a psychiatric facility.
Yes, I think that's what we were talking about. And then the question is, does that require a building in addition to the 300,000, right?
I mean,
For the residency?
Or can it be
You don't
absorbed?
need a building for the
I know.
Apparently, there are enough buildings to accommodate
We have lots of
a
hospitals.
facility without having to build one. I believe that's correct. Okay, more questions, more comments.
My name is Susan, and I'm currently in an APR program over at Gonzaga. One of the things that I had been working on was the fact that in addition to the residencies for the nurses and MDs, we also need residencies for the social workers for them to gain their clinical practice. And I'm already appropriate. I already have a position once I am done. And that's up in Lincoln County, which is probably in maybe worse shape than a lot of other counties. But our intent is to open that up to social workers and nurses in order to recruit for ourselves also.
Now, presently, are you at the U of M doing the social work training, or?
I'm in Gonzaga.
But we have the U of M that does provide degrees in social work. Would that
And it could be open to
dovetail
You can
with more psychiatric emphasis?
Pardon me?
With more emphasis on mental health issues?
We do a lot of internships. I mean, we do internships with the university system and social workers as much as we can.
Aspects of my story that are really typical, and then there are aspects of my story that are atypical. And I'm gonna
Come out and represent such a positive, healthy role model of recovery.
We have what we call the Alliance in Billings, which is the 3 major healthcare providers.
The day when he's really alert and can focus on his work. And then somebody this morning talked
into getting the world a better place. And it's both true, because the professionals actually need the resources, the payments.
Some of the policies that we are driving are targeting those kinds of issues, but it's not like it's
analogy as opposed to an electrical line analogy, the circuitry and learning.